Okay, I think we'll go ahead and get started for the next session. I want to get done with my talk before they start playing the music, and you sort of have to start dancing around and get you off stage. So I'm going to cover some recent clinical updates and a little bit of background on treatment of pancreatic cancer with radiation. But I also want to present some data that's a little bit more forward-looking. At the very end of the talk, I'll cover some of the preclinical data that might be very promising for pancreatic cancer, and maybe in a few years we'll be talking about clinical trials based on some of the preclinical data. So these are my disclosures. I guess currently I do have NCI grant support, but depending on how things happen with our government, I may not even have to disclose this in the future anymore if the funding really is threatened as much as it is now. This is what Houston looked like. So you can say global warming, but we had a big snowstorm in February, and this is the main street where MD Anderson's. This is Holcomb Boulevard. So you can see it's covered in snow, and it really shut us down for a couple of days. So really unusual, but please, if you're ever in Houston, please come visit. We usually don't have snow like this. So this is the outline of the talk. I'm going to cover really the role of radiotherapy in the management of pancreatic cancer, but highlighting some of the SABR approaches for pancreatic cancer, both from mostly from a definitive treatment standpoint, but also a little bit of a palliative intent. And then I'm going to also cover a recent clinical trial that I think has really changed how we think about pancreatic cancer, particularly in the context of oligometastatic disease. And then lastly, the preclinical study. I'll cover a little bit of data on ferroptosis as a target for pancreatic cancer. So in the US, every year, this is data from 2025 from the American Cancer Society, there's over 67,000 deaths, slightly improving. Now it's resulting in about 52,000 deaths. It used to be that the incidence rate was directly equal to the death rate. But overall now, if you take all stages, the 5-year overall survival is about 13%, whereas it used to be low single digits, maybe 5% about a decade ago. So I'd say not a home run by any stretch, but some modest improvement over the years. And a lot of this improvement has really come from improvement in systemic therapy. So these are two really important studies, both published in the New England Journal, showing an overall survival benefit of FOLFIRINOX chemotherapy versus gemcitabine. So for many years, decades even, gemcitabine plus drug X was shown to be no better than gemcitabine alone until these investigators decided, well, let's just change the backbone completely and added throughout gemcitabine and replaced it with FOLFIRINOX. And lo and behold, although there's more toxicity associated with this treatment, there's a substantial improvement in overall survival. And this was published in the New England Journal in 2011. So this is probably the first real improvement in pancreatic cancer in a couple of decades. And then a couple years later, Dan von Hoff and his group published that the addition of Abraxane to gemcitabine also showed a benefit compared to gemcitabine alone. So now most people would consider as frontline chemotherapy either FOLFIRINOX or nab-paclitaxel gemcitabine as frontline treatment for pancreatic cancer. And we usually decide based on how fit the patient is. FOLFIRINOX is a little bit more toxic than Abraxane, so that might be something we would consider in deciding who gets what up front. But surgery remains a mainstay of treatment, and many of our therapies are really geared towards getting the patient to surgery. So this is just a cartoon that says, let's just start cutting and see what happens. A bunch of surgeons operating here. But many of the studies really are always compared to surgical resection as the backbone of therapy. So this is some randomized data looking at patients that were treated with gemcitabine postoperatively or modified FOLFIRINOX postoperatively. So remember, these are all patients that have undergone surgical resection. So these are the most favorable prognostic group. And with adjuvant FOLFIRINOX, the median survival is 54 months, so almost 5 years. That's really unheard of, a decade ago. So I think there is some cause for optimism, particularly in those patients that can undergo surgical resection. Adjuvant treatment with FOLFIRINOX appears to confer a substantial survival benefit. compared to gemcitabine adjuvantly. So what's the role for local treatment in a disease that we've historically thought of as really a systemic disease, pancreatic cancer? This is a rapid autopsy series from Johns Hopkins, and I like to review this data a little bit because in these patients, about 30% of these patients will die primarily of local disease with minimal or no distant metastases. These investigators correlated it with the presence of the SMAD4 tumor suppressor gene. The loss of this tumor suppressor gene results in systemic progression or metastatic disease. So when about a third of patients die primarily of local disease, it is these patients that probably benefit the most from an intensive local treatment such as radiotherapy. So we do need better biomarkers to really select the appropriate patients for this kind of treatment. But the basic rationale for the use of radiotherapy in pancreatic cancer is as follows. With increased improvement in systemic chemotherapy, there's more of a role for local therapy. And about a third of patients will die of primarily locally invasive disease, and uncontrolled local disease can result in pain and or obstruction. So even if we're not curing patients, we can provide a substantial clinical benefit by just eliminating or reducing pain and or obstruction. So there are 3 modern trials. I'm going to go over these relatively quickly that probably many of you in the audience are quite familiar with these data. The LAPO-7 study is the one I'll talk about first, but this was a randomization scheme in which 442 patients with locally advanced pancreatic cancer were randomized first with 2 different chemotherapy regimens, gemcitabine versus gemcitabine plus erlotinib, which is an EGFR inhibitor. And then if they had stable or better disease, there's a secondary randomization to either continuation of whichever chemotherapy they were on or radiation plus Xeloda or capecitabine to a dose of 54 gray. These are the results of the first randomization. There was no benefit for gemcitabine, for erlotinib addition to gemcitabine, which was surprising because there were previously randomized data in the metastatic setting where the addition of erlotinib did confer a very modest survival benefit, but that was not reproduced in this LAPO-7 study. But here's really the meat of the study. Then in the secondary randomization, there was also no benefit, survival benefit for chemotherapy alone versus chemoradiotherapy. The median overall survival was 16.5 months in the chemotherapy radiotherapy arm, or in the chemotherapy only arm, and 15.2 months in the radiotherapy arm. So this pretty much was a very disappointing study and really didn't demonstrate any survival benefit when radiation was added after induction chemotherapy. The progression-free survival, though, the trend with the p-value of 0.06 was that chemoradiotherapy was slightly better than chemotherapy alone, 8.4 versus 9.9 months. So these are the additional summary of the results. The local progression in the chemoradiotherapy arm was 32% versus 46% in the chemo-only arm. But I think this is a key point, that in those patients that received chemoradiotherapy, they had an increase of 6 months versus 3.7 months off of any therapy, including particularly chemotherapy. And so this is probably an indicator of improved quality of life in that patients could be spared additional months of chemotherapy if they received chemoradiotherapy. So these are the official conclusions from the investigators. There's no survival benefit when chemoradiotherapy was added after induction chemotherapy. We saw an overall survival of 15.2 months versus 16.5 months. The interval without additional treatment was improved, 6 versus 3.7 months. And local regional progression was decreased with chemoradiotherapy, 32 versus 46% in favor of the chemoradiotherapy arm. Some criticisms of this study is that about 18% of these patients had a major deviation in the radiotherapy, and at least 20% that were randomized to chemotherapy received chemoradiotherapy off protocol. Okay, now switching gears, this is the ECOG study. This study did show a survival benefit, but it was closed due to early due to poor accrual. So only 74 patients were actually enrolled, and this took many years for the ECOG to complete this study. So really you could think of this as a significantly underpowered study. But this was a randomization between gemcitabine alone versus gemcitabine for radiotherapy. The radiotherapy dose was 50.4 gray in 28 fractions. Gemcitabine is a very potent radiosensitizer, so I think the investigators wanted to give a slightly lower dose than the 54 gray you saw in the LAPO-7 study to account for this. And here are the survival data. Gem plus radiotherapy conferred a overall statistically significant increase in overall survival, 11.1 months versus 9.2 months with gemcitabine alone. However, there was more toxicity, including grade 4 and 5, 41% in the chemoradiotherapy arm versus gemcitabine 9%. There's one grade 5 toxicity in each arm. So quite an increase in toxicity. So this regimen is generally not used today. And then this is the French study. Again, I'm going to go through this very quickly because the conclusion of this study is it was stopped prematurely because there was overall worse survival in the chemoradiotherapy arm. But these investigators treated to 60 gray, so probably too high of a dose with concurrent 5-FU cisplatin, too much toxicity, and so this study was stopped early. Here are the survival curves. Again, this is the chemotherapy or the gemcitabine only arm versus the chemoradiotherapy arm. And here's the chemoradiotherapy arm and the gemcitabine alone arm. So worse overall survival and worse progression-free survival. So the major criticisms of this study is that they used large fields and they treated the entire duodenum to 60 gray. This is too toxic. And only 42% of the chemoradiotherapy group received 75% of the planned treatment. And this is a key point too. This study design was not based on any phase 1 or 2 data. So the cisplatin was not standard and the 5-FU dose was not standard, and this was basically too high of a dose and too toxic. So these are all the reasons why this is probably a negative study. Okay, so now, up until now, I've been talking about conventionally fractionated radiotherapy. Now I want to say something about what we currently use in a lot of cases is either hyperfractionated radiotherapy or SBRT. So when you give radiation in a single large fraction, you result in greater cell kill than if you're giving it in multiple smaller fractions, because you don't have to overcome this shoulder region of the survival curve on a daily basis. This shoulder region is thought to represent DNA repair. If you give radiation in one large dose, you only have to overcome this one time. And so for the same dose, you get greater cell kill. So that's kind of the concept for either a SABR approach or a hyperfractionated radiotherapy approach. And so the rationale is it's more dose intensive, so potentially you're increasing local control. You can sterilize surgical margins, shorter course of treatment, allows better integration with intensive systemic chemotherapy. It's more convenient for the patient, and it is cost effective compared to conventionally fractionated radiotherapy. And these are the kind of dose distributions that you can get. You can see this hypodensity. This is where the tumor is. This is the 100% dose. It's carved right around the tumor, and you can really bend dose around the duodenum. This is the 50% isodose line, and you're sparing the duodenum and small bowel and colon here. So at MD Anderson, what we use is Koong in-room CT. So we have a CT on rail system, and this is a patient I treated a couple years ago. This is the simulation scan. This is the hypodense mass. You can see the bowel here. But on the first day of treatment, you can see that this bowel floated very close to the yellow line here, which is the 36 gray line, and is even overlapping with the 50 gray line shown here in red. So had I not had the ability to see this on the first day of treatment, we would have treated this patient, and if we had given all fractions like this, we would have overdosed the bowel that had floated into this area. We asked all these patients to fast overnight before their treatment, but despite doing that, this bowel was in the way. So in this case, I asked the patient to get off the table, let him walk around a little bit, and came back later in the afternoon. But same thing happened here. The bowel is still in this location. You don't see it over here in the simulation scan, but it's right in this high dose area. So again, we aborted this treatment and asked the patient to come back the next day. And indeed, in the next day, it looked better. It's still not, the bowels are not exactly in the position it was ideally at the simulation, but it had floated away enough, and particularly was outside of the high dose area here, shown here in red. And so for that reason, we felt comfortable treating the patient when we went ahead and did this. So this is just a reminder that in order to do this kind of treatment, you need really precise treatment and you really need great image guidance in order to ensure that there's no bowel in the high-dose areas when you're treating. This is a patient that I treated on the MR Linac. It's a little bit hard to see from the back of the room, but this is a locally recurrent tumor and a pancreas tumor. And what's nice about this kind of a situation is you can see where the bowel is, and you can see the pancreatic tumor throughout the course of the treatment. And so I think the precision, I'll show some of the data later, is even greater in this particular scenario. Okay, so this is the first multi-center study that we ever did with SBRT. We used SBRT up front with a single cycle of gemcitabine first. At this time, we're using a dose of 6.6 gray times 5, and we did the study at Stanford, Johns Hopkins, and Memorial Sloan Kettering. And what we reported here was overall median survival of 3.9 months, almost 14 months, and so this was pretty respectable at that time, particularly in the gemcitabine era. We did see some toxicities, and remember, we included ones that are possibly attributable, whereas some of the other studies only reported toxicities that were definitely attributable to the radiation. So we're probably overestimating some of these toxicities, but the more serious ones are grade 2 and higher, and about 8.5% of our patients had either developed an ulcer or even a GI bleed. 2%, this is really one patient, developed a fistula, and then one patient died, but he died of local progression, probably eroded into a blood vessel that caused the death. But we attributed this as possibly to radiotherapy. So the summary from this study is that it was feasible. This is the first multi-center SBRT study ever done, and that multi-fraction SBRT results in less toxicity compared to single fraction. The freedom from local progression was almost 80%. And we saw this was quite useful for palliation of pain in these patients. And so this study warranted further investigation. What about intensified chemotherapy in SBRT? This was a retrospective analysis from Stanford. Diego Toesca, one of our fellows, did this study. So he looked at almost 150 patients, and he compared those that received less than 40 gray versus greater than 40 gray, and also FOLFIRINOX versus gemcitabine. And in this study, what he found is that those that received greater than 40 gray, shown here in the blue line, had improved freedom from progression compared to those that got less than 40 gray. And then those that got modified FOLFIRINOX did better than those that got gemcitabine alone. This is progression-free survival, and really not much difference between gem versus gem Abraxane. And FOLFIRINOX looked better than gem Abraxane, but again, these are kind of small numbers and not statistically significant. The main finding here was that higher dose appeared to be better than using 40 gray as the cutoff. The LAP-PC1 study was a prospective study looking at FOLFIRINOX for 8 cycles, so the kind of modern way of how we do this treatment now. And they received 8 gray times 5 for stable or better disease, limited the duodenum dose to 35 gray, and about 50 patients, 39 gray received SBRT. They had slightly different criteria for locally advanced pancreatic cancer, and you can read them here: 90% involvement of the SMA, or the celiac axis, or greater than 270-degree involvement of the superior mesenteric vein or the portal vein. So in this study, the median overall survival of the SBRT versus the non-SBRT patients was 18 months versus 5 months, and the local control was 81%. So very respectable. Remember, in our study, we had a 1-year local control of 78%. So this pretty much recapitulates our findings, even though we had a different radiation fractionation scheme. And then those that were able to undergo resection, of course, did the best compared to those that were not able to undergo resection. This is a meta-analysis now, so looking at multiple studies, pooled all the data, over 1,000 patients. There were 11 studies looking at conventionally fractionated radiotherapy versus 9 SBRT studies, including some prospective and some retrospective studies. And what these investigators found is that the 2-year overall survival was improved in those that got SBRT versus conventionally fractionated radiotherapy. You can see all the studies here. These are the SBRT studies down here, Here's the kind of the median survival in the 2-year survival, and you can see it here in the conventionally fractionated. So slightly better, 13% versus almost 27% with those that got SBRT. Surprisingly, there was also no difference in toxicity. The acute toxicity was actually better with SBRT, 5.6% versus 37.7% in the conventionally fractionated radiotherapy. But the late toxicity was no different. So even though we're giving high dose per fraction, it was 10 versus 9% grade 3 or 4 late toxicity. So there's no difference between conventionally fractionated radiotherapy versus SBRT or SABR. And in our country, in the US, it's generally 5 fractions or less is how we define SBRT. So a few contraindications that we've learned over time. If there's direct invasion of the stomach or the duodenum, that increases the risk of an ulcer, so we generally try not to treat these patients with SBRT. If there's significant amount of bowel or stomach involvement, increases the risk of perforation. And if there's large volume regional adenopathy, these patients need a larger field to be treated, and probably it's not ideal for SBRT. So based on these data, I've only gone through some of the data, but this has now become standard of care or an acceptable standard of care in the US. So the ASTRO consensus guidelines published in 2019 included SBRT conditionally, with 85% of the panel recommending that treatment. And the NCCN guidelines published in 2020 have now included SBRT as an acceptable option for locally advanced disease, and this was a 2A recommendation. Okay, so now I want to cover a little bit of this study. This is published in the Red Journal. This is a SMART study using, it's a phase 2 single-arm study using a 5-fraction stereotactic radiotherapy approach using an MR LINAC. These are the eligibility criteria. These patients were treated to 50 gray and 5 fractions, and really the primary endpoint was looking at toxicity. This study did include some patients. 43% of these patients had borderline resectable disease. So remember, these are a prognostically better group of patients than truly locally advanced, and about 56.6% of these had locally advanced pancreas cancer. So this is kind of the type of dose distribution that they can get. You can see here's the high dose area, and then they're able to carve dose around adjacent structures. The yellow here is the 33 gray isodose line, and the red is the 50 gray isodose line. About 65% of these patients receive FOLFIRINOX, and 17% almost received gem-Abraxane only, and then some were switched between these two chemotherapies. So these all had induction chemotherapy for up to 6 months. And so the results here, this is the main conclusion. Grade 3 toxicity or higher was 0. Now remember, these are what the investigators deemed as definitely related to SMART. There were a few that were possible at 90 days, but this is their primary endpoint. So 0 out of 136 patients had toxicities using an MR LINAC. Now, when you looked at some of the other toxicities, including those that were probable and possible, there were some additional ones listed here as well. But all grade 3 toxicities that are at least possibly related was only 8.8%. This is quite good. This is their survival, and again, very respectable results at 1 year, almost 80% survival at 1 year. A little bit about ablative radiotherapy in this context. These are retrospective data from MD Anderson when we looked at BED greater than 70 versus less than 70. Again, this kind of recapitulates some of the data from Stanford. Higher was better in this particular case. These are data from Memorial Sloan Kettering using an ablative radiotherapy technique, and they also reported quite impressive results with high-dose radiotherapy. But a word of caution about interpretation of these data. Remember, in the Memorial data, they reported median overall survival of 19 months, which is very good for locally advanced pancreas cancer. But they treated patients with SABR after chemotherapy. So they had up to 6 months of either FOLFIRINOX or gem-Abraxane chemotherapy. And these are the data from the Stanford, Hopkins, and Memorial study where patients were treated at 6.6 gray times 5. So not ablative, but median overall survival was 14 months. But if you count if you account for this, 19 months median overall survival versus 14 months, but you take into account the induction chemotherapy, which was given in this case, and the fact that this was only gemcitabine versus FOLFIRINOX and gemabraxane, probably the 14 months would have been improved to a similar degree if 6 months of chemotherapy were given up front and this were given with either gemabraxane or FOLFIRINOX. Okay, so this is the SMART study now. This was reported at ASTRO, and they compared the 5-fraction regimen of SMART versus the 15 or 25-fraction hyperfractionated radiotherapy given at Memorial Sloan Kettering. And this is not a direct randomized study, but this is a retrospective comparison of 120 patients that received HART versus 91 that received SABR. And what this comparison showed is that those that got the 5-fraction SBRT or SABR treatment had a 85.6% 2-year overall survival versus 69% with HART. And you can see these curves here. So the conclusion is that while it is feasible and safe to deliver ablative radiotherapy with the MR-Linac or other image-guided technique, it's also feasible to use in-room CT. But I think the key is that you need some type of image guidance. Multi-fraction SABR, somewhere in the dose range of 40 to 50 gray in 5 fractions for pancreatic cancer is effective and is a standard of care option, particularly after induction chemotherapy. And I think when we look at these dose escalation studies, we have to have a little bit of caution in interpreting exactly what they mean because we have to put it in the context of the era in which these patients were treated. Okay, so I'm going to cover a little bit of data now with oligometastatic disease. So this is the EXTEND study. This was a multi-center randomized phase 2 study carried out at MD Anderson. And we included patients with 5 or fewer metastatic lesions to define oligometastatic disease. Key exclusion criteria is that peritoneal carcinomatosis was excluded, and we use ablative therapies. So the dose was at the discretion of the investigator, but all of these patients receive high-dose ablative radiotherapy to these oligometastatic sites. The primary endpoint was progression-free survival. We use RECIST criteria to determine progression or clinical progression or death. And then this is a key point too. Crossover was permitted to the metastasis-directed therapy arm, the MDT arm, at the time of progression at the investigator's discretion. This is the consort diagram. A total of 41 patients were randomized. The characteristics are shown here. They're roughly balanced between the two arms. Again, these are more the characteristics of the patients. I'd just point out here that a higher number, 71% of the patients in the control arm versus the MDT arm received no prior chemotherapy. So this is a better group of patients prognostically. The ones in the MDT arm, 47% had at least one line of systemic chemotherapy versus 19% in the control arm. So the results, 47% of the MDT patients versus 29% of the control patients had progression after at least one prior line of systemic chemotherapy. Total of 33 sites were treated. 94%, the majority of these patients received external beam radiotherapy, but 2 patients did receive radiofrequency ablation, which is allowed as one type of ablative approach. And most commonly, those that got SABR received 50 gray and 4 fractions. These are mostly liver mets. Or other metastatic sites received a hyperfractionated regimen, 70 gray and 10 fractions. So this is the key finding from this result. The progression-free survival was statistically in favor of improvement in the metastasis-directed group. Median overall survival was 10.3 months versus 2.5 months in the control arm. And so this was a study that was surprising to us in this result because we think of pancreas cancer as a systemic disease. and what would be the role of local ablative therapy to a handful of metastatic sites. We were quite surprised to see this improvement in progression-free survival. The overall results showed that the MDT was beneficial in both the low and the high CA19-9 groups. So even those with high CA19-9 have a worse prognosis, but even in those patients, the local ablative therapy was better. Overall survival was not different, 12 months in MDT versus 10 months in the control arm. But remember, when patients progress, we allowed crossover between the two arms, so that could certainly dilute some of the effects of the ablative radiotherapy. And then this is where it really gets interesting, is in those patients, we collected blood pre and post radiotherapy. And in those patients that we saw an increase in T-cell receptor clonal expansion after the radiotherapy, they did the best. So that's shown here in blue, this increase in T-cell receptor diversity, or as a readout of a systemic immune response, was significantly improved in the patients that received the ablative radiotherapy versus in those that just got the systemic chemotherapy arm. So this is sort of an exploratory analysis, and more work is being done to follow up on this observation. So in summary, randomized study supports the safety and efficacy of metastases-directed therapy for oligometastatic pancreatic cancer in those patients with 5 or fewer lesions. Currently underway is a confirmatory randomized phase 3 study. So hopefully in a couple of years, we'll be able to come back and tell you the results of those studies. And what we are following up on is to explore the interplay between the systemic immune activation as a possible mechanism for why MDT may be a benefit and conferring a survival benefit. Okay, and now in the last part of the talk, I want to cover some of the data that's emerging from the laboratory suggesting that ferroptosis may be a promising therapeutic strategy in pancreatic cancer. So as tumors grow and they get to distances away from blood vessels, they start to encounter low oxygen or hypoxia. Nancy Lee covered this a little bit in her head and neck trials this morning. But at these distances away from blood vessels, these tumor cells are still viable, they're generally quiescent, and they're generally resistant to all kinds of therapy. So it's really trying to target this group of tumor cells where we may be able to see some improvement in survival of pancreatic cancer patients. There's multiple signaling pathways that are turned on in these areas that are at distances away from blood vessels. So these are triggered by hypoxia, low glucose, low pH, and it triggers an ER stress response pathway, also known as the unfolded protein response pathway. I won't really go into too much detail, but a key protein here is an ER transmembrane protein known as IRE1. When it's activated, it can dimerize and oligomerize, and resulting in activation of this protein. And this protein, one of its primary functions is to splice or activate the XBP1 mRNA, resulting in the splice mRNA and production of a potent transcription factor that then goes to the nucleus and has a whole set of target genes. These target genes are thought to help tumor cells survive the stress of that they encounter in the tumor microenvironment, and also can trigger metastases. So we and others have been focused on blocking the activation of XBP1 as a therapeutic strategy, not just in pancreatic cancer, but in a variety of other cancers. Ferroptosis is an iron-dependent mechanism of cell death. This is distinct from necrotic cell death and also from apoptotic cell death, and it's executed by phospholipid peroxidation and generation of reactive oxygen species, and by these phospholipid-containing polyunsaturated fatty acids, and is catalyzed by lipoxygenases. It's implicated in cancer therapy, particularly in radiotherapy, which can induce the production of these PUVAs and generation of the reaction oxygen species, and can result in ferroptosis. So ferroptosis-inducing agents are a novel class of cancer therapeutics that are under clinical and preclinical development. But radiation resistance is one mechanism of radiation resistance is related to blocking these ferroptosis or cell death pathways. So that's one area of active investigation by not just us, but other labs around the world. So these are just some original observations showing that in these lung cancer cell lines, that when you give a ferroptosis-inducing agent, you can sensitize these cells to radiation. So these look like classic radiobiology studies showing that ferroptosis inducers can function as radiation sensitizers. We recently, I won't show all the details of this study, but we showed that RE1, the key enzyme of the UPR pathway, is responsible for the degradation of a couple of key proteins in the ferroptotic pathways that lead to glutathione synthesis and GPX4, which is a key enzyme that blocks ferroptosis. So by blocking these pathways, we can trigger ferroptosis and overcome radiation resistance. We showed that when we deleted IRE1 from the kidneys of mouse tumors in an ischemic reperfusion assay, this is the control, we can generate these areas of lipid peroxidation and cell death. But when we knock out IRE1 from these tissues, we protect these normal tissues from ferroptotic cell death. It's quantification of that data. These are the same set of studies, except instead of using a genetic strategy to delete IRE1, we used a small molecule inhibitor. And again, we can block the induction, the formation of these lipid forming areas and blocking ferroptosis. So just a word about KRAS in pancreatic cancer. RAS is commonly mutated in pancreatic cancer. About 90% of pancreas cancers have a KRAS mutation. In particular, this G12D mutation accounts for about 40%, and another common mutation, G12V, is about a third of these pancreatic cancer patients. And these mutations lock the KRAS in a GTP-bound or activated state that leads to cell proliferation and increased cell survival and growth. And it promotes survival and resistance to therapy. What we did is we treated these mice using a SARP, a small nanomolar radiator, and we could show that in the presence of this BODP stain, which stains lipid peroxidation in response to radiation or ferroptosis induces, we get this rightward shift showing that this correlates with increased lipid peroxidation or activation of ferroptosis after radiation in these mice. Here's some other BODP curves, but in this example here, we gave radiation, that's shown here in green, and then when we add MRTX, which is a RAS inhibitor, we get a further right shift in lipid peroxidation at a couple different doses. And here's the most surprising finding, is that these mice were implanted with a pancreatic tumor orthotopically, and untreated, they died rapidly. With SBRT, we could slightly improve the survival, and with the RAS inhibitor, we can improve survival beyond what the radiation alone does. But the combination treatment, these mice are basically cured of these tumors. I have an update now. These animals are out to 200 days now, and with no evidence of disease. So this is a very aggressive pancreatic tumor model, and the presence of the combination of SBRT plus this RAS inhibitor shows us a great improvement in survival of these mice. So we are repeating these studies, but we're hoping that eventually we'll be able to do clinical studies with these RAS inhibitors that are now entering the clinic in various trials. So mechanistically, what's going on here? This is kind of a busy graph, but if you just focus your attention here, we developed a inducible KPC cell line that could turn on the RAS mutant RAS. And we looked at the induction of UPR target genes or anti-ferroptotic genes in the presence of this G12D mutant or in the presence of hypoxia. And either stress alone doesn't do much, but when these stresses are combined, we see massive upregulation of the UPR target genes and of these anti-ferroptotic genes. I won't go into this data over here, but then in humans now, after preoperative chemoradiotherapy, we looked at some of these spatial transcriptomic signatures, and we can see this hypoxic signature in these pancreas patients, and this correlates what you see here in red with a ferroptosis resistance signature. So this suggests that this process is going on in human patients, and further work is being done to develop additional ways to target both the hypoxic areas as well as drugs that can trigger ferroptosis in this context. So some overall strategies to overcome radiation resistance: development of ferroptosis inhibitors for normal tissue protection, development of ferroptosis inducers or FINs for cancer therapy, and a combination with radiation and other cancer therapies are all various strategies to overcome radiation resistance. And there's going to be a differential between normal tissues and tumor. And so we have to really understand the biology to exploit this difference from a therapeutic standpoint. Okay, so I just want to acknowledge the patients and their families who contributed to the oligometastatic study, which I talked about earlier. And our funding sources are CPRIT at MD Anderson for these studies. Chad Tang was the overall PI, and Ethan Ludmir was also a key investigator in the oligometastatic study. And these are the members of my lab that contributed to the studies I showed, but in particular, Yuming Guo here, Dadi Zhang is shown here, and Tianyu Wang were the key folks that did a lot of the ferroptosis studies that I described, and Ethan Ludmir was the PI of the oligometastatic study. Funding sources from CPRIT, this from the state of Texas, and from the NCI. So I think I will stop there, and I should be just ahead. Yeah, so happy to take any questions. Thank you very much. Yeah.
I'd like to ask, because there are currently a trend of using total neoadjuvant treatment in pancreatic cancer, but there are still controversy in the perfect regimen in total neoadjuvant treatment. And I would like to ask, what's your recommended regimen for total neoadjuvant treatment in pancreatic cancer?
I'm sorry, I missed that. For total what?
Total neoadjuvant treatment in pancreatic.
Total what?
Total neoadjuvant treatment.
Oh, for pancreas cancer. Yeah, I mean, in general, our approach is to start with systemic chemotherapy, right? And all of these patients, for most of these studies, they receive anywhere from 4 to 6 months of chemotherapy. And generally, at that point, the patients can't tolerate more chemotherapy. Their blood counts can't tolerate it, or they've lost too much weight and other things. So it's usually at that point that we think, okay, well, what else can we do? Particularly something with non-overlapping toxicities. And so that's often our approach is, start with about 6 months of systemic chemotherapy, and those patients that have stable or better or responding disease, ideally, we like to see the CA19-9 starting to come down or at least stabilize and no evidence of new metastases. I think those patients that continue to have persistent local disease, those are the patients that I think can benefit the most from an intensive local treatment. So in our case, our approach has been either SBRT or SABR, or this hyperfractionated radiotherapy, where we try to treat patients to 6 to 750 in 15 fractions. Both of those approaches, I think, are can be thought of as interchangeable, and we sort of customize that to the patient. But both of those approaches require a high degree of image guidance to make sure that bowel is safely out of the high dose radiation field. But that's our general thinking with regards to neoadjuvant treatment. And of course, in some of these patients, particularly the borderline patients, or even some of the resectable patients, we can treat in this manner, and then of course they'll go on to surgery. And I think that then becomes sort of the overall goal and the definitive treatment in these patients. But some of these patients, based on the internal anatomy, they'll never become resectable. And these truly locally advanced patients are extremely difficult, if not impossible, to convert to radiographically resectable. But I think in some of these patients, we're able to sterilize the disease. So then it makes you ask the question, well, does the surgery matter? If we can, kill the tumor cells using, a high-dose radiotherapy approach, does it really benefit the patient to remove scar tissue or dead tumor? Probably not. So we're not quite there to say that we want to omit surgery, from these patients, but certainly I think that there's a subset of patients that maybe don't benefit from surgery when the radiation and the chemotherapy is highly effective. Yeah. Yeah, I think that means we have 5 minutes, right? Okay. Yeah.
Do you use proton therapy for SBRT for pancreatic cancer?
Yeah, that's a great question. So historically, we haven't. And that's because our proton center, we opened it, we call it PTC1. We opened it in 2006. And back then, we did not have this kind of image guidance. But we just opened our newest proton therapy center last year. And that does have all the latest image guidance, including CT on rails and Koong beam CT and those kinds of things. And we're still in the process of commissioning. And when we complete all of the commissioning, we do anticipate that we will be using some kind of hypofractionated approach for protons, including maybe a 5-fraction SBRT kind of an approach to treat these patients. There are data from other centers that protons may be beneficial. Probably, the data from Japan with carbon ion is the one that a lot of people cite with the higher LET particles. In those patients that were reported, they did quite well. Very favorable 2-year survival and 3-year survival. So we'll see. I mean, don't know yet, but I think we are certainly going to explore some prospective studies using a hypofractionated radiotherapy approach, whether it's 5 fractions or 15 fractions. Probably do a combination of those, and hopefully be able to report back to you what our results are. Oh, okay, yeah, right here.
Hi, I'm Dr. Lai. Thank you for your exciting talk. So I have some questions about the IGRT part for like the daily on-rail Koong beam, on-rail CT. So after you see these bowels inside of the treatment field, what else do we do by other than fasting? Do you do other bowel preparers for these patients?
Yeah, I mean, not really. We asked them to fast, and I mean, in that one example, this is anecdotal, right? I just said, well, why don't you maybe sleep on the other side and try to flip the bowel over to that side. I don't know if that worked or not, but that bowel did move out of the way. I think it's just the normal variation of where bowel is and, normal peristalsis, and, that can result in some amount of bowel that moves around. And I think that probably, some of the early days of SBRT where we didn't have the ability to image in the immediate area surrounding, we probably were overdosing bowel, and that probably explains some of the toxicities that we saw in the early days of SBRT. But nowadays, with either enhanced imaging using Koong beam CT or CT on rails or MR Linac, I think we can see where the bowel is more or less almost in real time from when we're treating. And we can make these adjustments. And so I think some of the reasons why we're seeing less toxicity now is that we can look to see where the tumor is and see where the bowel is and make adjustments, whether it's adaptive radiotherapy or, in the case that I showed here, we just have the patient get off the table and come back the next day. Those kinds of things, I think, are ways that we can limit the toxicity to patients. And I think that will open up this area for other types of approaches and maybe even increase the dose intensification with the radiotherapy.
Spacer for these kind of lesions?
I'm sorry, what?
Spacer.
Oh, yeah, and there are some centers, injecting something between, a biodegradable polymer between, the duodenum and the pancreatic head tumor and moving that out of the way, yeah, I think that could work as well. So any way that we can get separation from where you want to deliver high dose to the tumor and from the surrounding normal tissues, I think would be of benefit. And there's lots of different strategies, and I think they can all be effective. Okay, I think that means we're done. So thank you very much.